Honourable Minister Motsoaledi for joining us to present this memorial lecture in honour of Professor Stephen Lawn. I'm now going to hand over to Professor Ntusi, who's going to give a formal welcome to the Minister.
It's a fantastic pleasure to be with you today to welcome the Minister of Health to our faculty today. As our Dean has said, Stephen Lawn was a friend, a colleague who, during a very short but productive period at the University of Cape Town, made seminal contributions to our understanding of tuberculosis and HIV. And I can think of nobody who is more fitting to deliver this year's third Stephen Lawn Memorial Lecture than our current Minister of Health. Dr. Aaron Motsoaledi has made a number of important contributions during his time as Minister of Health to life of South Africans, and I wish to just highlight two main contributions. Firstly, in the area of HIV and AIDS, where we have seen a major reduction both in incident rates of infection as well as the mortality rates, coupled with higher numbers every year of people who have access to antiretroviral therapy, thereby improving the quality of life and longevity of patients infected with HIV. Simultaneously, during this period, he's also made, through policy interventions and his active work, a number of important contributions that have been foundational in the limitation of the spread of tuberculosis in this country. And in fact, at the end of 2018, he was the recipient of the Kochov Prize, which is an annual prize started in 2006 to recognize important contributions to infectious diseases. And he received this on behalf of the people of South Africa. And this was really an acknowledgement of the contributions he's made in leading the efforts to combat the dual scourges of HIV and TB in this country. So with those few words, welcome, Minister. We very much look forward to your words, and I invite you to come to the podium.
Thank you very much for the warm words. Let me also recognize Dr. Reno Mora, who is the Chief Operating Officer of UCT and the Interim Dean of the Faculty of Health Sciences, Professor Caroline Williams, also Professor Ntobeko Ntusi, the Chair and HOD of the Department of Medicine, Professor Robin Wood, CEO of the Desmond Tutu HIV Center, and Professor Linda Gale Becker, the Chief Operating Officer and Deputy Director of the Desmond Tutu HIV AIDS Foundation. Distinguished guests, good afternoon. It gives me great pleasure to deliver the Stephen Lawn Memorial Lecture at UCT this afternoon. While I was unfortunate not to have met Professor Lawn personally before his premature departure from our world, his passion for Africa and his work on tuberculosis has impressed me, as it has thousands of others working in the field of TB. as well as, of course, our patients. Professor Lon worked in Ghana as well as South Africa, together with his partner, Professor Joy Lon. His work at the Desmond Tutu TB Center included the work on what is called the LAM urine rapid test, or the lipo-arabinomannan, now used in the public health sector for the diagnosis of TB, especially in HIV-positive patients with low CD4 counts. Like a dedicated clinician researcher before him, Professor Lon leaves us with a legacy that we need to take forward with the same passion that he had for people with TB, especially those who were co-infected with HIV. His pioneering work has resulted in over 250 publications, including many influential papers pertaining to the rapid diagnosis and screening for TB, and making important contributions to the World Health Organization guidelines. Why will Professor Lon dedicate his whole life in pursuit of treatment and diagnostics for a centuries-old disease which has a cure and has been having a cure for many, many years? Steve did so because TB is still a very, very misunderstood and troublesome disease. Yes, it is curable, I'll keep on repeating that. But it is presently #1 killer of all infectious diseases. It has infected 10 million people globally, but only 6 million are known and are on treatment. The other 4 million, who are called the missing 4 million, and are lurking somewhere out there in society, unknown and without treatment. Each one of them is capable of infecting 15 others within their lifetime. Each country around the world has got its own fair share of the missing 4 million. Ours in South Africa is estimated at 160,000. Few people, even in the medical field, know that TB, over the past 200 years, has killed more people than malaria, cholera, yellow fever, bubonic plague, influenza, polio, Ebola, HIV, all of those added together. TB has killed more people than that number. This is a fact that many people don't know, nor do they believe when we repeat it again and again and again. In the field of antimicrobial resistance, TB alone contributes to 1/3 of the caseload. Regardless of all these facts, TB still remains largely ignored in some corridors of power, or generally not feared like other diseases by the general population. At best, it is still regarded as just one of those ailments. And at worst, it remains in the shadows. Even our world icon, Tata Nelson Mandela, warned the world about TB as far back as 2004 at an International AIDS Society conference in Thailand, when he said the world has made fighting HIV AIDS an important goal, and this is a blessing, but TB remain largely ignored. He went on to say, as long as we don't stage a battle against TB, we will not win the fight against HIV and AIDS. I think it took the world 14 years to take heed of Tata Madiba's words, because it's only recently, in 2017, that the United Nations took a decision to call a high-level meeting of heads of states to New York to come and talk about TB. And it also happened because we had to push. I am presently serving, I think, up to September as the global chairperson of the Stop TB Partnership Board, which was established by the World Health Organization. It's now falling under the United Nations Operations Program, UNOPS, what is called UNOPS. As the chairperson, the United Nations invited me to New York in a debate about antimicrobial resistance. And I raised an issue there: how do we sit in that type of a meeting, talk about antimicrobial resistance and how to combat it, when we know that 1/3 of it is contributed by TB, but TB is largely ignored? I pleaded with the United Nations that, like all the major diseases, there must be a high-level meeting, and I'm very happy that it actually did take place, because we wanted heads of states to know what we are faced with in the field of medicine. You know, other known killer diseases are spoken of with so much fear that action against them is usually swift and cannot be missed by anybody. I don't want to be misconstrued and misunderstood as undermining the devastation that other killer disease can cause to the world. But I just want to take this opportunity to demonstrate, by way of comparison, what I'm trying to assert to. Let's take a disease like Ebola. Everybody fears it, obviously for good reasons. When it struck in West Africa, Parliament here in Cape Town summoned me 3 times to reassure members of Parliament that the Department of Health in South Africa has done everything within its power to make sure that Ebola will not arrive at our shores, or if it does, that we'll be able to deal with it before it causes devastation. And 3 times I went to reassure them. But still, some politicians slipped into some hospitals secretly. And when I arrived in Parliament, they challenged me. Minister, I've been to that hospital. I know we are not ready. Cholera is going to finish us. When I ask them what they saw in that hospital, they usually can't tell. But somehow they know that I've slipped in there and we are not ready to handle Ebola. In other words, it was showing the anxiety and the worry which people got because of Ebola. Professor Shabir Mahdi, who then was the director of the NICD, the National Institute of Communicable Diseases, once shared the platform with me on national TV speaking about this problem. And he said, I know that many South Africans are worked up and fearful about Ebola. And he said it's about 4,000 kilometers away. Oh, excuse me. These things can embarrass you at the wrong times. He said it's 4,000 kilometers away, and because of its mode of spread, it's unlikely to arrive here. And he said, if you are a South African, you want to be worked up about the disease, that is TB. That is the one that is more likely to kill you as a South African than Ebola. I still remember the swift reaction of the Twitterati and the social media when they were attacking him, that he's trying to make them fools. And one member of the public even tweeted that just because we are not professors, we are not fools. We know that this professor is lying. In fact, one suggested that he has been sent by the state to divert attention from Ebola by telling us about this TB thing, which we know is not a problem. We suspect the state is not ready to handle Ebola and they just want to cause a diversion, and they've sent this professor to do so. But what happened? Exactly 12 months after Professor Shabir Madi uttered those words, 11,000 people died of Ebola globally. In South Africa, not a single person died of Ebola, of course, because it never arrived. But TB, during that same period of 12 months, killed 40,000 South Africans. And globally, it killed 1.5 million people during the same period. You compare the 11,000 and 12 million, of course, if Ebola was not handled, it could have killed more. But I'm just trying to demonstrate how some of these diseases are feared, but TB is not feared, regardless of causing the devastation. I remember calling the trade union movement immediately after being elected in Seattle in 2013 as the chairperson of the board of the Stop TB Partnership, because now I've got access to all this information and statistics. I remember calling the trade union movement to indicate to them that in 2009, they've lost 80 mine workers due to rock falls. And we've heard about it because it induces anger, anxiety, and irritation that the mining bosses do not regard safety as important or as serious. They do not regard the life of mine workers as important. And so there was anger, but I was demonstrating to them that that is okay because it will bring changes. But in the same period, when 80 mine workers died of rock falls, 1,500 died of TB. Now, if there's no activity around it, there won't be safety from TB. People will keep on getting it. And I said the reason is because TB is very unique. I joined the Stop Partnership board in 2010 as a member because South Africa is a high-burden country. We spent 5 full days in Washington on a retreat to try and get an answer. Why is TB causing such devastation and killing such numbers? But it's not moving us. It's not moving researchers. It's not moving activists. It's not moving doctors. It's not moving ordinary villagers. It's not moving people in the corridors of power and the general population. What are we missing in this battle against TB? We even called people who specialize in marketing and branding. We spent 5 days with them. At the end of the 5 days, we still did not get an answer. We only arrived at one conclusion, which I suspect is next to the truth. And I'm using my own words. We thought it's because TB is not a drama queen. The other disease will arrive with pomp and ceremony and noise. And they just hit us, pa! TB doesn't do that. It's very silent, and it kills you in isolated location. And giving an example of these mine workers, it's because a rock fall, you are with a colleague now, 15 minutes later is dead. And it invokes emotion. With TB, you are with a colleague, get infected, get the symptoms after some week, coughs, go home, isolated from you, forget about them, and they go and die silently at home. And nobody is moved by that. That is the danger of TB. So we need to be very careful when we deal with this disease. Now, let me return to our local context here. As is well known, South Africa has a dual epidemic with a 60% HIV positive patients also co-infected with TB. It's not the other way around. It usually confuses people that anybody with TB also has got HIV AIDS. It's not like that, but we're just saying 60% of HIV positive people are also co-infected with TB. So this makes TB and HIV two sides of the same coin. This makes it critical that researchers, whether they are lab-based scientists or those that focus on implementation science, think about issues related to how to prevent and treat patients who are co-infected with comorbidities. Needless to say, my passion to deal with these two diseases robustly arises from their contribution to morbidity and mortality in South Africa. Because in my country, whether we are measuring life expectancy or neonatal mortality or under 5 mortality or maternal mortality, these are all significantly impacted by both TB and HIV. Round about 2009, 50% of maternal mortality in South Africa was attributable to HIV. And of course, a fair number of them will get TB. 50% of under 5 mortality was also attributable to HIV. And of course, a fair number of them will also get TB. And of course, we knew that then, that 80% of all HIV deaths are actually caused by TB. Only the remaining 20% are caused by all the other complications which people with HIV/AIDS suffer. So our response to these two diseases since 2009 has borne fruit, even though we are still not out of the woods. According to the latest South African Medical Research Council's Rapid Mortality Surveillance Report, estimated mortality rates between 2009 and 2017 are as follows. Neonatal mortality remained unchanged at 12 per 1,000 since 2009. Infant mortality declined from 39 per 1,000 to 23 per 1,000. Under 5 mortality declined from 56 per 1,000 to 32 per 1,000. Maternal mortality declined from 302 per 100,000 deliveries to 134 per 100,000. Life expectancy increased from 57.1 years to 64.2 years. All of this because two diseases were being dealt with. In addition, State South Africa, from their audit of death notifications, suggest that the number of deaths as well as percentage of deaths from TB out of the total deaths has declined since the year 2006. 76,881 deaths ascribed to TB were recorded in 2006, compared to 399 in 2016. That's a 62% decline. And part of the reason was the number of people who are HIV positive who were now accessing treatment. At the present moment, we are putting 600,000 new patients on ARVs every year. As a cause of all-cause mortality, TB death declined from 13,000 then in 2006 to from 13%, from 13% to 6%. While these statistics are encouraging and suggest that we are beginning to turn the tide, I'm sure that everyone will agree that these numbers are still far too high for a country of our level of development. But this is also true globally. There is progress globally, but unfortunately, it is far too slow. And this pace, this slow pace, is the one that motivated us to encourage United Nations to call a high-level meeting. At the rate at which the world is dealing with TB, if nothing changes, especially before New York, it is estimated that to reach the World Health Organization targets will take 190 years. So while we celebrate the new diagnostic tools and medicines that we have today, which we didn't have just 5 years ago, we must know about this fact. Today, we now have GeneXpert, which has helped us to cut the period of diagnosis of TB from the time you give a sputum to 1 week. The GeneXpert can do it in 2 hours. And I'm happy to announce that South Africa became the first country on this planet to distribute GeneXpert to all facilities. We even introduced it to correctional services. I'm sure we are aware by now that within the population of South Africa, there are 3 major groups that are largely vulnerable to TB. Number 1 is people in correctional services. Number 2 is mine workers, especially those who work in gold mines because of the high association of silica dust with TB. And gold produces more silica dust than any known mineral for now. And number 3 are people living next to the mining dams, people who the World Health Organization calls peri-mining communities, who have never worked in mines and are victims. And our figures show that that actually is true. We are aware that in the 80s, 80% of the gold of the world used to come from South Africa. It built many of our cities, especially Johannesburg. But today we are silently paying a huge price for that. Because when we check what gold has done in terms of the prevalence of TB district by district, number 1 district is Lijuele-Butswa in the Free State. If you look at where Lijuele-Butswa is, it's around Welcome and Virginia. Even when you pass overhead in a plane, you can see the yellow mining dams all over a city like Welcome, and we are paying the price for that. The second prevalence, the second highest, is Kenneth Kaunda district in Northwest. It's around Orkney, which is known for gold mines. The third is Western in Johannesburg, around Carltonville, which is a gold mining area. And you can go on and on. It's around those. The metros, all our metros added together are responsible for 40% of the TB cases of South Africa. eThekwini Metro is number 1, followed by the Cape Metro here where we are. We understand and we know that eThekwini Metro is like that because of the high prevalence of HIV/AIDS in the province of KZN. Maybe just to put you in the picture, when we follow the prevalence of HIV/AIDS in the country, number 1 is KZN, number 2 is Mpumalanga, number 3 is the Free State Province, number 4 is Gauteng, number 5 is Northwest, number 6 is Eastern Cape, number 7 is Limpopo, my home province, number 8 is Northern Cape, and Western Cape is number 9, the lowest prevalence of HIV. But when it comes to TB, it's the other way around. I've put scientists together to try and give me the reason for this phenomenon. We have not yet got answer, and I'm sure the scientists, Linda, you are still searching. What is the reason for the Cape Metro to have such a highest prevalence of TB when the HIV/AIDS is so low, when in the others we can map? And you know, I haven't heard of a gold mine here in the Western Cape. Yes, but those are some of the things. That's why I said TB is still a disease that is very badly understood, even though science is so advanced. So we because of the correctional service being number 1, we had to divide them into 7 clusters. And each one of the clusters has got its own gene expect machine. And we launched it here in Pollsmoor prison in 2011. In memory, not in memory, at that time, because we're thinking about what happened to Nelson Mandela when he was in Pollsmoor prison. That's why he got this TB. Linda, I don't know, because this is not an accolade, but I usually say it internationally. I don't know its worth. I tell them we're the only country in the whole world, because no country can describe something like that. We are the only one where 2 Nobel Peace Prize laureates suffered TB. That's Desmond Tutu and Nelson Mandela. I don't know what is the worth of that, but I like saying it, and I'll leave it with you. So that's why we went to correctional services. In the mines, we hired 9 inspectors and said the mining bosses cannot push the responsibility to the state. We hired 9 inspectors to go from mine to mine just to check if mine workers are being screened for TB. Because in the correctional services, we are screening now. Since we launched in 2011, our policy is to screen every inmate when they arrive, screen them twice during their stay, and screen them when they go home and follow their families. And we're insisting that mining houses must do the same. And I'm happy to announce that only a year after we have done that, 90% of the mining houses were now screening their workers for TB. So we're happy that we have got this gene expect. We're also happy that we have got this LAM, which has got a very difficult name. I don't want to repeat it. I'll usually twist my tongue, which, of course, was brought to us by the men we're celebrating here today. We also have got new drugs now, because the world is starting to wake up. We have got betaquilin and delaminate, and I'm happy to announce that we are far ahead of other countries in introducing betaquilin to people suffering multi-drug resistant TB. Globally, there are now 28,000 people with multi-drug resistant TB who are on betaquilin, and 20,000 of that number are South Africans. To remind everyone, key commitments from the high-level meeting in New York on TB, which we need to take forward to meet the Sustainable Development Goals are 5. We call them the 5 asks. We met in Moscow, in Russia. I think it was in August, or was it November? November 2017, to prepare. Well, let me not mix the date, but we met to prepare for this high-level meeting. And I'm very happy that we were starting to realize just how damaging this TB is, because in that meeting, 80 ministers of health around the world attended, 2,000 delegates, the Director General of the World Health Organization, the Deputy Secretary General of the United Nations, the Executive Director of UN AIDS, the President of the Russian Federation, all shared the platform to prepare for this high-level meeting. And we agreed at that time that we are going to present 5 asks to the heads of states. And we did so. Number 1 ask was to find and successfully treat 40 million patients, including 3.5 million children, 1.5 million with drug-resistant TB, and 115,000 children with drug-resistant TB. By 2022, around the world, we must have put an extra 40 million people, including these children. And before I go on to the 4 asks, some of the puzzling things about TB, how do we explain to ourselves that despite the advance of technology, right up to now, when newborn babies suffer TB, we still have to break a tablet because we didn't have children's syrup for TB, but we have got them for other medicines. Those are some of the problems that we are still faced with, regardless of the fact that there are 3.5 million children globally who suffer TB, and 115,000 of them have got multi-drug resistant TB. So that is the first act that we need to do. The second one, prevent TB in 30 million people, including 4 million children under the age of 5, and 6 million who are also having HIV by 2026. Number 3, to implement the UN/WHO resolution on antimicrobial resistance, which has also been to the high-level heads of states. Number 4, to improve coordination between HIV and TB programs. In our country, we battled to convince nurses who had their own timetables. Monday, family planning. Tuesday, TB. Wednesday, antenatal care. Thursday, HIV. Taking one human being, dividing them into different parts, where some people were forced because of that regime to have to visit the clinic 3 times in 1 week. You know, it's not possible. But to coordinate them and say, please, do them together in 1 day, it was very difficult. It's very difficult, especially for HIV, AIDS, and TB. With a co-infection or comorbidity of 60%, it was logical. But it was very difficult because people had different cultures and were trained in different ways in their areas of training. And number 5, to improve the social, economic, and structural drivers of TB, HIV, viral hepatitis, NCDs, of course, especially diabetes. I'm sure you are aware by now that people who are diabetic are 5 times more likely to get TB than people in the general population. So what does all this mean for South Africa? I will summarize what we have already done and what we plan to do going forward. Our estimate is that, as I said earlier, we are missing 160,000 people who have got TB and who have not been diagnosed. We have undertaken and put up a program to find at least half of them, at least 80,000 by the end of next year, who must be put on TB. And between January and December 2018, actually, I'm sorry, it's not between January, I still remember very well, it's from April, just from April to December 2018, we found 38,000 South Africans with TB who were hitherto unknown. And our simple method of finding them was contact tracing. Get all the people who come to our clinics and hospitals who have got TB, follow them home and screen the whole family. Just that exercise unveiled 38,000 people who have got TB just between April and December. You can imagine the number that is still out there with TB, which, if not followed up, will of course complicate. And we are using community health workers. That's why we are emphasizing that the healthcare system must put more emphasis on primary healthcare than what we are doing today. And primary healthcare means hiring more community health workers to do this. However, we must do more and better. And therefore, I call on all our health workers to be vigilant, to screen everyone that comes to our facilities. I made this call even last week when we were celebrating World TB Day in Eastern Cape. I said we must have a policy where anybody who ends up in a hospital, for whatever reason, must be screened for TB. After all, it's so prevalent, it's #1 killer. So whether you go for family planning, you're not sick or what, they must subject you to some screening. And by screening, I don't mean taking your sputum or X-ray, just being asked 5 oral questions and get those who answer in a particular way to those questions, take them forward to do some of the tests. We need to do that. And I'm busy putting together a policy which I'll put to the National Health Council, the highest decision-making body in health, that perhaps the time has arrived that all health workers must be tested for TB. Not screened, tested. Screening, the screening we're talking about, we mean first being asked 5 oral questions about night sweats, about coughing, about loss of weight, about chest pains, etc. And then taking it forward depending on the answer. But testing means line up all the health workers maybe once a year and put them through a gene expert or an X-ray or whatever, because many of them are vulnerable. My heart breaks when I visit Brook Lane Clinic here. The number of nurses who I can't even look in the eyes, and you can see from their level of bitterness, they don't have ordinary TB, they have got multi-drug resistant TB, which they got from patients. The number of doctors who also get multi-drug resistant TB, we think the time has arrived, and we believe very soon we'll be introducing that policy that all health workers must just be tested once per annum, and the rest of the population we start by screening exercise. But of course, those who are directly affected, like family members of those who have got TB, we have to visit them, like where we got this 38,000 from. So equally, I call all employers to have work-based screening programs, like the ones that the mine workers are having. But in addition, we want leaders to communicate. On the 24th of March, we were here in the cathedral because we were targeting traditional leaders. religious leaders. Last year, we targeted traditional leaders, and Queen Goodwill Zelitini led a course in Durban, whose son is also one of the TB ambassadors, and he's moving around with me. He was here last week, and he's a very good ambassador. He's not scared to show it. During the event last year in KZN, he stood in a full stadium on the stage, took out his shirt, and showed people a scar when they were removing one lung from him because of TB. As this audience may know, we have already deployed Gene Expert Ultra. It's a very big one. Let me not go into the details. But we have also put HIV patients on isoniazid prevention therapy. There are 958,559 people around the world who are on isoniazid prevention therapy, and 373,838 are South Africans. In order to increase this case finding, we have motivated from Treasury to give us an additional 485.3 million for the financial year 2019-2020, just for tracing and putting on treatment these missing people. And we are very happy that amount enabled us to find this 88,000. So this shows the commitment of the South African government to strengthen TB program. Equally, we are partners with the rest of BRICS countries and are working within TB Research Network to conduct research that will assist not only BRICS countries, but all countries to develop new tools that will enable us to eliminate TB by 2030. I'm sure you are aware that 3 different organizations has made a call that we must eliminate TB by 2030. It is the United Nations itself through the high-level meeting, which I've mentioned. It is the World Health Organization. It is the Stop TB Partnership. But despite this achievement I've mentioned, much more work needs to be done. And I think Linda knows that, and all the people in this area, that we've said this many times. If, and only if, we get a TB vaccine, the game will not change. TB vaccine is a game changer. And it's again one of the conundrums of TB. Why over 200 years, but we still don't have a vaccine? When we had vaccines for diseases like Ebola, which are very recent. That's another question that we need to answer to ourselves. BCG is now 114 years old. But a repurposed BCG is being researched with a need for a booster. Point-of-care diagnostic like we have for HIV is still a problem. New medicine to add to betaquilin and delaminate, including shorter-acting, long and active medicine. Equally, we need to ensure that these new technologies are affordable. And I think that's important to show that low and middle-income countries, which bear the brutal brunt of TB epidemic, can afford them also. Many people might not know that taking it in totality, when you calculate the payment of staff, laboratory staff, treatment, etc., we are spending about 400 rand to treat the person with TB. But once they develop drug-resistant TB, we spend 400,000 rand for each patient. When they develop extreme drug-resistant TB, XDR, we spend 800,000 rand. Not surprising why the private sector in this country is refusing to touch TB, regardless of all the resources they have. And sometimes they believe I'm attacking them, but this is true. For those of you who are middle class, if you want to die, go to a private hospital when you've got TB. They don't know how to treat it. Yes, you have got to come to the public sector, to the academic institutions and all the other hospitals if you really want to get help. If we are able to meet the SDGs target by 2030 or earlier, we'll be able to honor the legacy of Stephen Lon, as well as other researchers and clinicians who dedicated their life to saving the lives of others. Thank you very much.
Oh, for you. Now, it's a pity I can't turn water into wine. I really just want to thank the Minister for taking the time to be with us today, to share his passion and commitment to health system strengthening and to reducing the burden of TB in society. I'm particularly sad that Joy Lon, Steve Lon's wife, is not here, because I'm sure she would have loved to have heard your words in person. I would like to invite a few questions or comments for the Minister, and there's one from the middle. If you can introduce yourself.
I'm Anya. I'm working for Medicine Sans Frontiers in Canada. I was really excited, Minister, that you had drug resistant TB featured in your speech and that you mentioned access to new drugs such as Dilantin and Tadalafil. At the moment, I just wanted to bring forth a deep concern that I have. Dilantin is currently not available in the country. Dilantin is currently not available in the country, and I'm a care provider for people with rifampicin-resistant TB, and I'm well networked around the country, and all of us clinicians are very concerned because, as you know, we've got around 10,000 people started on treatment.
There's some bit of echo, if you could take it a little bit far.
Okay.
Yes.
I was saying 10,000 people are started on treatment, and of these, around 14% have extensively drug-resistant TB. And currently, those patients are not receiving an effective treatment because we don't have Dilantin. Our understanding in the field is that Dilantin is awaiting registration at SAPRA and has completed the clinical component and the pharmacological component, and it seems like there's just some logistical holdups in terms of it coming through SAPRA. And so I was wanting to appeal to the Minister to find out if there's anything at your level that could be done to ensure that the drug is registered so that we can access it for our patients.
Should I answer? Any other questions of the Minister? Maybe we'll take a few, and then you can answer them together. There's another one there at the back.
My name is Ndando Yola with the Desmond Tutu HIV Center, and thank you, Minister. On.
Are you coming for this?
No.
He's waiting for you. Not so. Oh, I see.
If you can just to wait
Well,
for.
I can.
Oh, yeah, it is working. So, I mean, I think, I don't know if you probably would blame us for being concerned, having known you for being one ambassador as a political head in health around the issue of TB, that we are now facing the May 8th, and we don't know what the implications are for that, because it is clear that political leadership and buy-in is very critical. As such, you have shown that, you know, how much concern should we have, and what is your role in really making sure, should you not continue to be the Minister of Health, we will still have this kind of leadership that is really helping us on the issue?
Perhaps, Minister, you can answer those two questions.
Yes. Thank you very much. The question from MSF, and thank you for the contribution you are making, not only in South Africa, around the whole world. Maybe you must give them a round of applause. Yes, as you know, yes, they are doing very good work in this battle. And in quite a number of cases, government follow after them rather than the other way around. The issue of SAPRA is a big problem for us as a country. And perhaps because I'm in an academic institution, I should also raise it. You are aware that we used to have MCC, Medical Control Council, and the backlog was maybe up to 6 years, where somebody has applied to register a drug, and before they get a response, it's 6 years. Every time we get money, we deal with that backlog. I remember how the British government at one stage helped us to clear the backlog with funding. Immediately, you clear it, it builds up again. So we eventually changed the Medical Control Council to SAPRA, South African Health Products Regulatory Authority, to make it bigger and more efficient. But the issue is we still need people to run that institution. The biggest problem are human beings. Just in comparison, of course, this is a ridiculous comparison, but I need to give it to you. The FDA in the US, the Federal Drug Administration in the US, has got 10,000 full-time scientists registering medicines. In South Africa, SAPRA still have 250, most of whom are not full-time, are in the universities, etc. We ask them to come there, evaluate, and go away. So this is still a big problem. And that's why we wanted to establish one of the institutions to start training PhDs on this issue of regulatory authority. Everybody comes to me, you are not the only one, you are coming because of your compassion. There are those who are coming because of business. I don't know how many people have gone to Tutu House to report me. Business people who, threaten that there won't be any investment, yes, to threaten me. All that we did to SAPRA, all I can do, which we started in 2009, was because of the place that HIV and TB occupy in the lives of our people. Any HIV medication and TB medication, and of course, medication for maternal health, we said they must prioritize them. And they are doing so, unfortunately, but even within that prioritization, as a minister, you are aware, I can't go there and say this one, and that one, and that one. I won't do that. But we are trying our best. I launched a delaminate program with the government of Japan at Swiss TB hospital in Gauteng, but it's still not programmatic. We're launching it as a small program, but we want delaminate to be registered. And I'm really begging them day and night. It's only that there is nothing I can do beyond asking them to, The second question, say, I'm sure you'll appreciate that, is a question I can't entertain or answer. Because I don't think there's a human being on this planet who has got an answer to this question at the present moment. Even the voters don't know yet. Even the president. And even if they announce the results on the 8th, he still won't be able to answer it. Because from my experience since 2009, when president decides who must go in what department, they might do it 5 minutes before they announce. After looking at all the factors. Yes. They might have put you there and say, no, we put this minister and all that. Just before the announcement, somebody will come and say, President, what about the gender balance? No, take out one man. And what about the geographic spread? So it's a question that we rather not even try to entertain. It's very difficult. Thank you. I'm sorry about that.
So what has in your plan to make sure that there is continuity around all this work that you have done, so that should gender balance or whatever issue comes, it doesn't really affect?
No, part of our reason of going to UN was exactly that let the heads of state bind themselves, let them be bound by UN, which won't change regardless of who the new Secretary General is. And these 5 asks are there at UN. And I'm sure you are aware that UN has changed its operations. We don't know how successful they'll be. If you remember, when they declared Millennium Development Goals in 2010, they were just declared with pomp and ceremony. And nothing was done until 10 years later, when we started realizing that we are far behind with the 3 Millennium Development Goals in health: maternal mortality, under 5 mortality, and HIV, AIDS, and TB. You remember that? Between 2000 and the year 2015. We took that decision and did nothing. Now, when the UN adopted the 17 Sustainable Development Goals, they said these ones, they are going to put special teams to try and monitor, to go to government, evaluate, do monitoring, and, you know, and show a country that you are lagging behind. So we are hoping because of that, this program will be owned by UN and heads of states, regardless of who holds whatever position. At least that is our hope.
Well, thank you, Minister. I think on that uplifting note, I'd like to thank you again for coming to spend the afternoon with us and sharing your vision of TB in the future in this country. I would like to invite Professor Linda Gale Becker to say a few closing words.
Thank you very much indeed, and I add my thanks, but I'd like to add, on behalf of a few additional people, a very special thank you, first of all, to you, Minister, heartfelt. And again, I want to actually ask the room, so of late, I find myself more in the HIV world, and when we hear something good or exciting, we clap, we say amen, we say hallelujah. This was a very quiet audience, but I heard a lot of firsts today for South Africa, lots of firsts where we haven't yet cracked the problem, but we certainly made a significant contribution around the world by being first on a number. So I want to thank the Minister. It's during his time that we had this. At this moment, I just want to draw people's attention to, again, to Steve and to his family. So Joy regularly and to date has been at every single one of the memorial lectures. She couldn't make it this time because she is being who she is, a very compassionate, very passionate neonatologist, public health specialist in her own right, and she's saving babies and mothers around the world even as we speak. So she couldn't make today, but she asked me to just bring to your attention that Steve would have been 53. And these lectures not only remind us of the fantastic body of work that he did, remind us that TB and HIV still need our time and attention, our thoughts, our research, our money, our passion, but also that it reminds us that, you know, there are these connections around the world. So even though Steve's family is based now in London, and here you see them, this lecture happens every year in Cape Town, and to date has happened in London and Cape Town. From now on, we'll be alternating between London and Cape Town. So next year, if you are available at about this time, we'll be in London, and then in 2021 we'll be back here. But on behalf of Joy, Tim and Joe, and this is Tim's long-standing girlfriend, we just really want to thank you for being here, and particularly to the Minister for being our third lecturer. Joy remembers that many people played a role in Steve's life, and many people have gone on to continue the work that he and others are doing around TB and HIV, and you'll see there are some of our own family here. So, Minister, you are very much in the epicenter of tuberculosis. I'm pleased to say that there's a lovely critical mass of people who are trying to get those answers for you and will continue to work very hard. Val Mizrahi, who leads the Institute of Infectious Diseases Molecular Medicine here, also gives her apologies that she was not able to be here this afternoon. She's away. But Steve's favorite saying was, it's not research, but we search. And so we continue to search. So just to remind you that the Memorial Fund is still ongoing. There are slips of paper in the front if you feel moved to contribute. That enables us to keep the lectures going. And we will do so until Steve would have been 60 years old. So these will continue until then. And to date, We have had Robin Wood as the first inaugural. Of course, Robin worked very closely with Steve. A good number of those papers in Tobacco are shared with Robin, mentoring and working with Steve in the years that he was with us. Last year, Liz Corbett and Peter shared the platform with Liz. Liz brought the second lecture. And of course, we're again really, really thrilled to have had Minister Motsoaledi this year, particularly following on the United Nations high-level meeting, which was such a stellar and very important milestone in this 150-year journey that we are on in terms of since we've known about tuberculosis. Just to say, last year Liz reminded us about the stamp trial. Minister has alluded to the lamb and the role that Steve and others played in trying to minimize mortality in those people particularly who have become very ill with HIV and TB. And this important trial was the last real clinical research that Steve was involved in when he succumbed to his cancer. So there is also a leadership prize, and the stamp trial reminds me that we want to encourage young researchers still to be doing seminal research in TB and HIV. So this prize, which is given out at the union meeting, is up for grabs at the moment. You can see how you can nominate individuals. So we're looking for junior researchers, young people who have not only done the research but written it up. So we're looking for really exciting peer-reviewed, published manuscripts that describe good research. And you can see a wonderful opportunity. There's a prize. You get your profile in the Lancet, which certainly, I think, contributes to networking. And we invite the winners to this meeting every year. And here are the two winners to date, Leonardo in 2017 and Christine in 2018. And right now, nominations are open. In fact, they closed last week, but we've asked them to extend for another week in honor of this lecture. So please, if you have someone in mind, or you can self-nominate, please do as soon as possible. And so on behalf of the partners and its London School, Peter Piot is very supportive of this. Ourselves here in Cape Town, Robin Wood and myself, as people who loved and cherished Steve through the years that he was with us. We want to thank you for being with us this afternoon. Again, Minister, thank you for coming to us from Johannesburg. We really, really appreciate your time and effort and the great contribution, more than anything else, the contribution you have made to the health of our country, and we salute you in that regard. Thank you to Ntobeko and Carolyn for helping us, and to my team, really brilliant. Thank you to everyone, to the team at UCT as well for helping us to keep this together. The folk who are live streaming this for us, thank you very much. And just all of you, please stay for refreshments so that we can just, again, network. Remember Steve, raise a cup of tea. Sorry, it's not quite the sundowner hour. But please stay, and we look forward to otherwise seeing you in a couple of years' time. Thank you so much.